We can crack on then, guys. So welcome to case studies number one. And this is the first of our two case studies series that we're going to be having here in our Ultrasound Plus course. So firstly, just want to say hi, nice to see you again. I want to ask you how you're getting along with your scanning. Obviously, we've covered everything in the abdominal section. I'm wondering how you're getting on since our last meetup in December. Anyone want to fill me in? You're just going to have to jump in and talk. Hello?
Okay, now I'm hi, it's Orla, and I would say I'm about the same, which is probably not great, but anyway, still trying.
Why are you about the same? Is there anything we can help you with?
I think it's just opportunity, unfortunately, in my practice. So
Okay.
it's just one of those things. But I'm still enjoying learning all about it. So one of these
Okay,
days
good.
it'll be great.
Yeah, and so you have access to this material ongoing anyway, so you
Yeah,
can also go back to it, which
yeah.
is always a good thing. And hopefully then when we meet again in June, isn't it, for our final practical day, we'll be hopefully able to show you some echo stuff. And anyway, some of the smaller parts and harder parts as well, as you're struggling with.
I'll announce there to the group that I won't be at the June one. I will
Oh yes, of
be
course,
somewhere with a
Jeff.
newborn, probably.
Oh, bless you. Yeah, sorry. Well, I forgot about that. And that's far more exciting.
Yes, so I'll catch up another time. But anyway, that's me. I said someone better answer you, so someone else can give you an answer now.
How's everyone else getting on?
Yeah, good. This is Kira.
Okay.
I feel like I've gone back a bit in like how much I'm scanning or the opportunities to scan. We are down a vet, like probably a lot of other people are understaffed at the minute, and it's just a bit chaotic, and things are just keeping our heads above water. So the opportunity to do like full in-depth scans is much like less, and I feel like I'm
Oh,
doing a lot more pop the probe on as I'm passing as opposed to sitting down properly. But hopefully it'll get back under control if you find someone soon enough. So
it seems to be the problem everyone's talking about at the moment, isn't it?
yeah,
Understaffing.
yeah,
I
yeah,
totally understand
yeah,
that. But well done for thinking about it and pop a probe on whenever you can.
yeah.
And one of the things I was saying to some people is if you can just get the opportunity, I think we mentioned this at the practical day, even just to just decide that week that on your space you're just going to check the gallbladder only that week, and then next time just the left kidney, and next time just the left adrenal. So you're practicing your numbers then on specific regions of interest, rather than trying to image the whole abdomen very quickly and not doing a proper job of anything. Just for for your practice, from a practice point of
Yeah.
view. Um, how's everyone else getting on? Jeff, you're there, I feel.
Yep, sorry for my audio. I'm on a train, so it might be a bit weird. So, um, I'm getting on okay. Probably haven't done the numbers since the last practical that I would have hoped to have done, but that's because there's been a few other changes of staff, and then I'm kind of expected to do a different bit of like different kinds of work. Um, but I'm definitely still like I haven't gotten less confident, and I feel like I'm good at utilizing ultrasound as a
Good,
kind of adjunctive to other diagnostics. So I kind of
good, good.
like, I feel like I know when to use it and what I'm using it for. Like I'm kind of using it for, I'm targeting things before I'm even, whereas before it was like, I'm kind of randomly kind of saying, well, it's booked in for an X-ray and an ultrasound, and we're just going to see what
Yeah,
happens.
yeah, yeah,
Whereas
yeah.
now I kind of, yeah, I'm lining up reasons to do scans. Um, Still, obviously, the time is a big issue with like, I could spend a lot of time if I wanted to, um, happily scanning adrenals, but then everyone's like, what the hell are you doing? You have to do some other work. So it can kind of be a bit, it can kind of be a little bit of a rabbit hole.
Yeah, yeah, of
Um,
course.
so yeah, yeah, but
I mean,
enjoying
I
it.
mean, to be honest with you, scanning the adrenal glands, it's not very often that you come across a pathology, but you can see in this image here, we've got a beautiful pathology. And if you didn't know how to find the adrenal glands, you wouldn't be able to recognize this issue, you know? So
Yeah,
it's about finding the anatomy, scanning and understanding what's normal so that you can spot abnormal fairly quickly when you come to those more challenging cases. But again, only a numbers game. So keep up the hard work, though. Fair play. Does anyone else want to chime in, or should we crack on? I take that as my sign to carry on. Fantastic. Okay, so before we begin, we do have some questions. We're going to briefly test our understanding of abdominal ultrasound. We've got 20 questions, and in the top right corner of your screen, you're going to see a timer, and it's going to be set for 20 seconds for those shorter questions and 30 seconds for the longer ones. So you're going to have to jump in and answer as quickly as possible. Sorry that we can't have the videos on. It makes it a little harder to kind of grab your attention. So let's see what we can do. Okay, so the first question is select the correct names for this artifact indicated here. There's 2 correct names for this artifact. Time's running out.
Distal acoustic enhancement.
Fantastic. Distal acoustic enhancement. And what's the other name for it?
Yeah.
Edge shadowing?
Edge shadowing.
Not edge shadowing. You may not know this.
Berber.
Oh, hi, Laura.
Hi, sorry, I'm here.
So the other name for distal acoustic enhancement, and it's what it's being called more commonly in more kind of up-to-date ultrasound studies, is they're calling it through transmission. Okay, so just to put this one in there, I know we haven't discussed the terminology as through transmission. I've never called it that, but I'm finding it called that more and more in the literature. So just be aware when you see this through transmission, if you are reading papers, that's what they're talking about there. Okay, right, next question. What are orthogonal images?
Two images at right angles.
Yeah, 2 images obtained at right angles to one another. Very good, Kira. Fantastic. And it's really important to make sure that when we are imaging we're looking at, a volume of a patient. We're looking at volumetric data set, and the image on our screen is a 2-dimensional representation of that volume of data. So it's really important that we obtain at least 2 views of the structure that we're trying to image to ensure that we're getting the best representation we can of the anatomy and the pathology in the patient. Very good. In which of these images would you say the gain is adequate? Image 1, 2, or 3?
2.
2.
2. I agree, guys. Absolutely. I would say 2 is probably the best one of the bunch. I don't think any of them are perfect. Okay. And we can say that maybe the first one's a bit too low, third one a little bit too high, and the middle one's probably just about right. But there is a degree, of course, of subjective and subjective personal preference. So it's important to understand gain adjustment. Again, we don't touch the gain too much, but if the gain is too low and the image is darker, subtle changes in the parenchymal organs can be missed. And if your gain is too high, you get that very much black and white image, and so the subtle contrast will be decreased. Question number 4. Distal acoustic shadow artifact may occur distally to, does it occur distally to a cololith?
Shadow colorless.
Yeah, it does.
Yeah.
Urolith?
Yes.
Yes.
Yes. Ribs?
Yes.
Yes. Cystic lesions?
No.
No. Dystrophic mineralization?
Yes.
Yes.
Yes. Gas?
No.
No.
Yes.
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 Talk about that in a minute. The edge of a curved surface?
Yes.
Shadowing. Yes.
Now, there is shadowing at the edge of a curved surface. You're dead right, but it is not the distal acoustic shadow, okay? It's not a distal acoustic shadow. It's not because something's blocking it. It's due to refraction, and that's edge shadowing. So it's a slightly different physical property. Okay, what about foreign bodies?
Yes.
Yes,
Yes.
okay. And gas, of course, is the one that caught you guys out there, obviously. And we do remember there's 2 types of shadows. You've got your clean shadows, which are cast by structures that have a higher density or higher acoustic impedance than the surrounding soft tissue. So your cololith, urolith, ribs, dystrophic mineralization, and foreign bodies, for example. And then you've got the type of shadow that's the dirty, hazy, murky grey distal acoustic shadow, your gas shadowing, which is cast by a structure that's got a much lower acoustic impedance than the surrounding soft tissue. So don't forget the 2 types of shadowing. What is the name of this artifact here, indicated by the arrow? This is inside a jejunal loop.
Distal acoustic shadow.
Very good. Distal acoustic shadow from a foreign body within so intraluminal foreign body in the gastrointestinal tract. Very good. Which image depicts a hyperechoic liver? Image 1 or image 2? You can tell they're 2 split screen images, okay?
Number 2.
Very good. Number 2. Why do you say that?
So it's brighter than spleen.
Yeah, it's isoechoic or even slightly hyperechoic to the splenic parenchyma. Very good, Laura. Well done. Okay, what artifact is present in this image?
Oh, mirror imaging.
Mirror image artifact. Very nice. So this is the diaphragmatic line that you can see here. You can see the gallbladder with the cololith. So this artifact results in two images of one structure and most commonly occurs at that liver diaphragm interface. So which structure in the image is the mirrored image? The structure closest to the probe or the one furthest from the probe?
Further.
Yeah, furthest from the probe. And it is important that you know that in case you ever go to sample it, you don't stick the needle into the fake image, you stick the needle into the correct image. Well done. Okay, name the numbered structures. We've got the right adrenal gland. We've got some anechoic tubular structures here then. So what do you think is adjacent to the right adrenal gland here? What's number one? You've got the kidney on the left of the image. You've got the right adrenal gland sharing its adventitia with the,
Aorta.
not the aorta.
Caudal
Vena
vena cava.
cava.
Caudal vena cava first. So this is when you're imaging it,
Aorta
okay?
second.
Aorta second, very good. Number three,
The cranial
Renal.
mesenteric.
very good. And number four?
Celiac.
Yeah, excellent, guys. Well done. If you can recognize that in that vascular anatomy, you will find the right adrenal gland. Fantastic. Well done. Okay, this is the long one. We have a 9-year-old female neutered domestic short hair. She presented following a finding of moderate azotemia on routine blood work. Subsequent ultrasonographic examination demonstrated bilateral renal lesions with a hyperechoic proximal interface and a
Distal acoustic
Distal
shadowing.
acoustic shadowing.
shadowing. Fantastic in both kidneys. What do these ultrasonographic features most likely represent? Cortical cysts, pyelonephritis, nephrolithiasis, or renal lymphoma?
Nephrolite.
Bilateral nephrolithiasis.
Yeah, exactly. I think I need to set the timers for longer, so don't feel the pressure because I can't read it that fast. Okay, next one. Identify the artifact indicated by the arrow here.
Distal acoustic enhancement. Oh, no, there's none. Sorry.
Yeah.
What was the other name for it?
Oh, true transmission.
True transmission. Fantastic. Guys, I tell you, it's written everywhere now. They talk about pathologies and they talk about then in the literature this through transmission artifact that's seen next to this pathology. So it's important that we do know that terminology has changed for some reason. So we've got two images here, image on the left, image on the right. So image number one, can you identify the region of the stomach here? We're looking at that's the section I'm looking at there. We've got the liver, the diaphragm interface. We've got a bit of stomach there. And we can see this section there. Do you see that? What is that? That bit there.
Pylorus.
Pylorus,
Not the pylorus in image number one, not the pylorus. It's a very cool image. You don't see it commonly. You see it quite commonly in cats and small dogs. I was very amazed when I started being able to find this structure. It's the cardiac sphincter. It's the esophagus going into the stomach there in image number one.
Wow.
Through the
Just
diaphragm.
showing
okay?
off now, Rosie.
Just showing off. It can be useful to find hiatal hernias, but it's not commonly done. Okay, so that's the cranial aspect, the proximal aspect of the stomach. What about an image number two? So we've got a panting patient here. You can see the image is moving a lot. Duodenum into the stomach.
That's the pylorus.
That's the pylorus there.
Pylorus,
Okay,
yeah.
beautiful pylorus within the patient. Okay, whereas you can see the esophagus there was right up adjacent to the diaphragm. Yeah, just showing off. Sorry, lads. Okay, what artifact is present within this stomach?
Oh,
Dirty shadow.
yes.
Yeah, distal acoustic shadowing, the dirty distal acoustic shadowing. So the colloquial name for this type of distal acoustic shadow produced by GI tract gas is, of course, that dirty shadowing, that hazy, murky grey, dirty distal acoustic shadow. Okay. Brilliant. So which artifact is most evident here? We've got an image of an oblique bowel loop and then two quite nice transverse images of vasculature there. And you've got a really nice example of this particular type of artifact here.
The edge shadowing.
Yes, so this is the edge shadowing artifact. You can see it off every single entity there in that image. It's a beautiful example of it. And just be mindful, okay, it doesn't matter so much in this particular image, but when you do have a kidney and you've got marked edge shadowing if the kidney is quite rounded, which of course the kidney is, then it can obliterate your visualization of the caudal and cranial poles of the kidney and might hide infarcts or hide neoplasms for you as well. Well done. Okay, accepted canine adrenal gland measurements. I'm just putting you through your paces here. What do we realistically accept a caudal pole measurement in a dog that's less than 10 kilos? What's the, I've given you options at the bottom there to choose from. Do you remember the measurements?
No.
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 5'4".
Yep, less than or equal to 0.54. Fantastic. 10 to 30?
0.8.
Nope, that's greater than 30.
0.68.
Yeah, very good. Well done, guys. Okay, so they're roughly the measurements we're looking for. Again, there's huge variation in the literature on this, but they're quite nice measurements to have in your head. And we'll be looking at some adrenal cases in a little while. The through transmission artifact may occur distally to a urolith. Yes or no?
No.
No.
Cavitated splenic lesion?
Yes.
Yes. Cystic lesion?
Yes.
Gallbladder?
Yes.
Yes.
Vasculature?
Yeah.
Yes.
Yes. Focal calcification?
No.
No.
Foreign body?
No.
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 Urinary bladder?
Yes.
Yes.
Yeah, so basically anything with anechoic content. Fantastic, guys, really good. You're brilliant at this. Regarding feline hepatic lipidosis, which is not a common ultrasonographic feature of this pathology.
No. It's okay. Heck, boy. Four.
4.
Yeah, very good. So with hepatic lipidosis, we don't typically see any changes in the gallbladder. If we did, we could start thinking about cholangiohepatitis or other issues that are involving the biliary tree, not just the liver. Very good, guys. 2 more questions. This is hard, sorry. How do these vessels appear with color flow mode? Okay, so a color Doppler. The patient's lying in right lateral recumbency. We're scanning the left side of the patient. And we're going to employ the BART color variance map. Okay, so blue away, red towards. What color will the left external iliac artery flow be with our probe? Red or blue?
Red.
Red? Fantastic,
Red.
Laura, well done. What about splenic vein?
Blue.
Blue, because it's shooting down to join the portal vein towards the other side of the patient. What about the portal vein?
Right. Okay.
It's going down towards the liver.
Blue.
Blue, so bringing blood from the mesenteries and the GI tract towards the liver. So it's usually away from our probe most of the time, so it's going to be blue. What about the left intrahepatic portal vein? So we're imaging the liver on the left-hand side.
Red.
Red, because remember the portal vein brings blood to the liver. Fantastic. So out towards the acute margins of the liver. Fantastic. Final question. We've got an 18-year-old female new to domestic short hair, demonstrated some interesting lesions in the hepatic parenchyma. We've got an artifact present that informs the most likely differential diagnosis. Isn't that beautiful?
Biliary mineralization, is it?
Yeah, this is intrahepatic biliary mineralization, and this is a patient we're going to have a little chat about in a while. Okay, very good. So we're going to move on to some case studies now. Hopefully that's woken us all up and delved a little bit further into artifacts, because I felt that was something we had a few questions about last time. Okay, so 5 case studies. Let's start with number 1. We have Maisie. She's an 8-year-old female neutered Yorkshire Terrier. Hyperexia of 2 weeks duration with occasional vomiting and diarrhea. Wasn't really the main concern of the owners. The owners reported the patient struggled sometimes to get comfortable in the evening time. And yesterday they noticed that she had quite a distended abdomen. So they brought her to the vets. Abnormal clinical findings, I've just included the abnormal ones here. She has a low-grade left-sided systolic heart murmur, no previous cardiac diagnoses, markedly distended abdomen with fluid wave, and decreased muscle mass along the spine. So, what would be a prudent initial workup for Maisie? Would you do a contrast-enhanced CT of the chest and abdomen first? Full bloods, echo, cardiac biomarkers and chest x-ray first? Fecal analysis and Giardia SNAP first? Full bloods, abdominal ultrasound, fluid sampling, or an AFAST and TFAST?
4.
4.
4.
I would do 4 as well. Yeah, I think 4 probably confers the most benefit initially for this patient, and we are talking about ultrasound, so I guess that might guide your decision there too a little bit. Okay, so an abdominal ultrasound was performed, and hematology, biochem, electrolytes were run in-house, and there was a mild regenerative anemia and rather moderate hypoalbuminemia. Hepatic and renal enzymes were within normal limits, so totally fine. Did a urinalysis. This was on a sample retrieved via ultrasound-guided cystocentesis, and it was really rather boring, the urinalysis was. So I would like you guys to give it a go, one of you to give it a go. There's plenty of opportunities to jump in and talk about images today, so hopefully everyone will give this a shot. So can someone jump on in and describe this ultrasonographic image for me, please? Or for us?
Mm-hmm. Fusion.
Laura, I can hear you mumbling, so you might as well just jump in.
No.
Come on, come on. I've labeled things for you, which is quite helpful.
Yeah, remember my what's the description thing?
The Röntgen signs. Yeah, they're not always helpful when you've got kind of a picture. It's more helpful for a focal lesion, the Röntgen signs, but they can definitely still be employed. Tell me what you see. Just tell me what you see in this picture.
Well, it's like effusion, like
Yeah.
deep to the duodenum, hyperechoic mesentery,
Very good.
and the jejunum looks diffusely probably thickened
Yeah.
with a very full lumen.
Yeah, distended. Very nice. Lovely. Anything else to add to that? That's beautiful. So there's loads of effusion. We've got hyperechoic mesenteries. Is anechoic effusion, if I was to be specific. The jejunum is markedly dilated, possibly thickened. We have no measurements here to be certain of. There's a lot of intraluminal content. But there's something else I would comment on. What do we talk about? We talk about the motility, thickness, and wall layering when it comes to the intestinal tract. Okay, how would you describe the wall layering? Is it normal?
No.
No. Okay, moving on to the next slide. Let's discuss the appearance of this wall layering. Compare it to that normal image there. If somebody wants to join in and do that, compare it to the normal image here. What's different about this wall layering?
It looks very mottled, and you can see each layer very clearly, even because it looks thickened. They look proportionally bigger than they should be.
Yeah, absolutely. So in the center is the lumen, just so you're all aware, that stuff with all the speckles in the very middle is the lumen, okay? Then we have the mucosa. The submucosa, muscularis, and serosa are kind of all joined together. We can't see them very clearly here because everything's just brighter than it should be, okay? But the mucosa is very, very bright, isn't it? Can you describe that mucosa in any more detail, anyone? It's obviously hyperechoic than it should be.
Hyperechoic striations.
Yes, well done, Kiris. These are striations. They're beautiful hyperechoic striations within the mucosa. So we've got a diffusely increased echogenicity of the mucosa, but also quite overtly prevalent hyperechoic striations. And what might hyperechoic striations indicate? Any ideas? What's it thought to represent, these hyperechoic striations?
The lacteals, or is that something else?
Yeah, dilated lacteals. So these are dilated lacteals within the villi of the intestinal mucosa. Fantastic. Okay, so we also have this other image obtained from our patient. It's her gallbladder. Discuss the appearance of the gallbladder, what might it indicate, and why might this occur? Anyone want to have a go at this one?
Is that the halo sign?
That's the halo sign. Well done, Ola. That's the halo sign, okay? It's a really beautiful example. It's probably the best example I've ever seen of a halo sign, where you get that beautiful kind of hyperechoic inner layer, hypoechoic layer, and then you do a very thin external layer that was only just about visible on this patient. So it's hyper, hypo, hyper like that. And you can see it's markedly thickened. Does anyone remember the normal thickness of the gallbladder wall in millimeters? Should it be this thick?
No.
No.
Usually less than a millimeter, okay? Maybe 1 to 2 millimeters at a push, but usually less than a millimeter. So this is 5 times thicker than it should be, okay? So this is the halo sign. What does the halo sign indicate?
It can be anaphylaxis, but
yes, but it very specifically indicates it's gallbladder wall edema, okay? So this is edema of the gallbladder wall. It can be a bit of inflammation too, but it is gallbladder wall edema, which can occur Due to anaphylaxis, absolutely, that's one of our causes. Anything else? What else can cause it?
Hypoproteinemia or hypoalbuminemia.
Absolutely, well done, Ola. Anything else? Several other options. So portal hypertension can cause it. Inflammation can cause it. Extrahepatic biliary obstruction can cause it, and right-sided congestive heart failure. That'd be your main guys. Okay. Sometimes acute pancreatitis, but usually you're going to find it most commonly for us is hypoalbuminemia. Okay. So that's probably our concern here. I think that's probably most likely, isn't it? We know the patient has low albumin, so could definitely be causing the gallbladder wall edema. Okay, so the ultrasound of Maisie was fairly unremarkable with regards to the spleen, hepatobiliary system, apart from the gallbladder, of course, and the urinary systems. There was evidence of that gallbladder wall edema. Most notably, there's diffuse changes throughout the jejunum. There was the increased echogenicity of the mucosa, manifesting as a generalized increase in echogenicity, but also as hyperechoic speckles and striations. So you can see both in this patient. And I think this is a very pretty pathology to behold. It's quite a nice one to find with ultrasound. It gives you quite a quick understanding of what the syndrome might be. So the bowel loops were subjectively thickened, although I find it quite challenging to discern a truly representative measurement, as they were also very distended, as you can see, the massively distended lumen with this to and fro motion of the intraluminal content. There was copious anechoic abdominal effusion, which we sampled and was confirmed as a transudate in this patient. So I want to point out these hyperechoic mesenteries again and ask you, why are the mesenteries appearing hyperechoic in this patient?
Probably because of the effusion.
Yes, I would say so. So we've sampled the effusion and it was transudate. So and there was no cells. We're not concerned for a peritonitis in this patient. So the two reasons for bright mesenteries: inflammation and an artifact secondary to the effusion. What's the name of the artifact?
Oh, that thing where it absorbs all the...
You've learned another name for today.
Oh. True transmission?
True transmission or distal acoustic enhancement. Fantastic. So two reasons for bright mesenteries. Either you have peritonitis or steatitis or local or generalized, okay, reactivity, or you have this distal acoustic enhancement artifact due to anechoic effusion in the abdomen. And you can see bright mesenteries even with a tiny amount of anechoic effusion in the abdomen, but here there's a lot of it. So the mesenteries are like little clouds. So again, what's happening with distal acoustic enhancement or through transmission is that the anechoic fluid inside this patient is anechoic. It is not sending any echoes back to the probe. So we know the probe is sending out pulses of ultrasound waves and is listening and waiting to receive echoes back from those tissues, okay, to generate an image. And if we hit anechoic stuff, so free fluid in this patient, then the ultrasound waves don't get sent back to the probes. They just travel through with gusto until they hit something that can send echoes back. And now loads of echoes get sent back because there's finally something that can send an echo back. And that gives a false impression of brightness. Okay, and that's how the distal acoustic enhancement artifact occurs in the mesenteries. It's tissue that can finally send some echoes back. Okay, are you all clear on that one?
Yeah.
Very good. So considering the signalment, history, blood work, urinalysis, and ultrasonographic examination, what is Maisie's most likely diagnosis?
Protein losing enteropathy.
Absolutely. So that's our most likely diagnosis. And again, we took fluid sampling and it was transudate. So ultrasonographic appearance of PLE. So I've very clearly pointed to the mucosa here for you with this pink arrow, just in case there's any confusion. Sometimes people think the lumen is the mucosa, but here's the mucosa here. So protein losing enteropathy, or PLE, is a syndrome in which the patient loses protein into the gastrointestinal tract. You guys know this. Patients often present with ascites due to the decreased vascular oncotic pressure from hypoalbuminemia. So as well as that abdominal effusion, which when sampled is typically a transudate, the ultrasonographic examination can yield those very pretty pictures that we see of dilated bowel loops that appear subjectively and objectively thickened. Oftentimes you put the probe on the patient, it's just bowel loops. That's kind of all you see. Often you have that overt increase, or very often that overt increase in mucosal echogenicity, and then the striations. The striations are kind of the worst cases that you see. And they're very beautifully depicted in this image here. You can see the transverse view of the intestines there. Those striations are really quite beautiful. So this patient did indeed most likely have protein-losing enteropathy. And so PLE is caused by a group of intestinal pathologies that are responsible for protein loss resulting in that hypoproteinemia. And underlying causes are going to include IBD, primary lymphangiectasia, which isn't that common, elementary lymphoma, chronic intussusception, massive worm burden, etc. But I think this is a very interesting one, is congestive heart failure. So congestive heart failure may interfere with the resorbing mechanism of the lymphatic system, which can lead to lymphatic hypertension and eventually PLE. So you can see that in your patients with heart failure occasionally as well. But PLE in Yorkies, we know that Yorkies are the PLE poster children. It's often due to concurrent IBD and lymphangiectasia. They have both. So the primary familial lymphangiectasia and IBD. So a genetic predisposition has been suggested in many studies, actually. So diagnosis of the underlying cause of hypoalbuminemia in these patients involves exclusion of renal protein loss by urinalysis and UPC and exclusion of hepatic dysfunction. But ultimately, if you want a definitive answer, intestinal biopsies are going to be required for determining what is or for confirming what is the actual underlying cause of the PLE. So when it comes to treatment, there's fastidious dietary control. I think it's still recommended to try just using a low-fat diet. If you had a better idea with IBD, you could go along with hypoallergenic, for example, but low fat's very important. I think people used to use the ultra low fat, but that doesn't exist so easily, or it's not so easy to find anymore, so low fat is recommended. Steroids are initially started anyway and often tapered down. Plus minus steroid sparing agents. Clopidogrel is recommended because they're pro-clotting. Metronidazole, I think a lot of people have put them on metronidazole historically, but there are now several studies that have demonstrated that metro might not confer any benefit in patients with IBD or acute diarrhea actually as well. So for our patient, Maisie, I think this case has always made me smile looking back at it, as I was the GP actually in charge of this case at the time, not just the sonographer. So I did both. And the patient was actually doing great until she had a major relapse. And the cause of this major relapse, she managed to climb onto the kitchen counter and make her way to the deep fat fryer and inhale about 2 inches of stagnant cooking oil. To make matters worse, this happened to be a recurring event. I swear this patient didn't know what was good for her. And eventually, on her 4th presentation, she came in with a distant aunt, and the aunt was like, she's moving to my house. I'm not letting her stay at her own house anymore. So she moved to another family member's house, and these family members did not, much to our patient's dismay, own a deep fat fryer. So regarding prognosis, it depends upon the underlying disease. There's normalization of plasma albumin levels within 50 days of initial treatment is associated with a better prognosis. So the mean survival time, typically less than 6 months, but patients can do well up to 1.5 years if the underlying disorder is fastidiously controlled. And I feel that I have seen patients do reasonably well, but I've seen patients, die relatively rapidly as well. I don't know what your experience is of that, guys. Have you seen any PLE cases yet yourselves with ultrasound?
I'm currently not with my ultrasound, but I'm currently dealing with a case that's been recently diagnosed as PLE suspect lymphangiectasia. And it's not really responding to the low-fat diet and the steroids at the moment. So I've been looking at these steroid-sparing options. Just what's because I was looking at Atopica is one of them, but extortionately expensive. Chlorambucil, but there are lots of young kids in the house, so I'm trying to stay away from that at the minute. I'm just wondering, are there any other options you'd recommend, or? I've had best luck with chlorambucil, but I've had very, very poor outcomes with cyclosporine, actually. I found the Atopica as well not to be that good. But again, it's been a while now since I've treated these, so that's going kind of back historically about 2 years since I last treated one of these. I give them a prescription as such an awful lot because I diagnose them a lot, but I often don't hear how they're getting on, unfortunately these days. But yeah, chlorambucil seems to be one that a lot of people jump to now, but I understand the concerns there. Has anyone else got any experience using anything else in these patients to help all it out? The other thing that kind of shocks me there is the mean survival time of less than 6 months. I don't think I've prepared this owner for anything near that. But I think that if you can help them with the underlying disease and the plasma albumin level normalizes, they can do reasonably well. And I find that they do quite well with the albumin level quite rapidly once it's corrected. And actually, this guy didn't have a low albumin level. Like we've caught it quite early, I think. Yeah, I'm just, if I need to start preparing this owner that she's going to lose her dog in 6 months, I need to start having some very serious conversations.
Well, I mean, you can recheck with ultrasound as well. I mean, I've rechecked these patients. This was, again, I haven't rechecked one of these in probably quite a long time now. But when I do recheck them, if they're well controlled, the bowel looks almost normal again. Almost normal. And I've seen dogs that have extremely bad mucosal striations and not be that bad clinically. And then I have dogs that are horrific clinically that don't have that bad mucosal striations, So that obviously, we think about diarrhea and gastrointestinal tract signs being very, very common, but they're not that common with PLE patients. I think that, and I can't remember the number exactly, but it is not that huge number. I think there's something like 30-40% don't have any GI signs at all. That's just me using my memory now.
So this guy is just weight loss, severe weight loss.
Exactly. Yeah, that's one I have at the moment as well, actually. It's just weight loss. I think he had diarrhea once in his life. Extreme weight loss. So I've actually recommended a full GI blood panel in that particular patient just to make sure that he isn't, checking TLI, folate, cobalamin, EPI, this kind of thing, looking for that as well, just to be certain. But I mean, his ultrasound definitely shows a lot of mucosal striations. So it's quite a nice ultrasonographic finding to help guide your next diagnostic steps quite rapidly, But I don't know if anyone else has any suggestions for all other medications.
Anything at all, lads. I'll take anything.
I know that one of the
things is Frenchie that no one can get near.
The first one I ever had was a Frenchie, and actually I was working in as it was a student actually at the time when I had this case, but I was kind of put in charge of it as a very proud little student. And one of the things that there was a medic there. She was a hepatologist particularly, and she loved low-fat cottage cheese. She fed it to everything,
really?
And it just increased the protein levels dramatically while still saying low-fat, so the zero-fat cottage cheese, and that really helped. She said so. It's something she swore by.
I'll take it.
Is low-fat cottage cheese in the clinic.
Low-fat cottage cheese, nice.
Not the tastiest thing, but they seem to like it. Okay, if we're good with that, we're going to move on to the next case. It's case number 2. This is Scooby. He's a 12-year-old male neutered Shih Tzu. You're going to find most of the patients were 12 for some reason in this particular set of case studies. The owner reports Scooby has been struggling to defecate at times, probably about a 6 months duration. Decreased interest in exercise with intermittent mild hind limb lameness. They were unsure about that. And there has been occasional hematuria. Abnormal clinical findings, again, only the abnormal ones. There was a grade 3 out of 6 left-sided systolic heart murmur. I think he'd had something present for a while. Tender abdominal palpation caudally and concern for prostatomegaly on palpation. So what would be a prudent initial workup? Plain CT of the chest and abdomen, bloods, abdominal x-ray, bloods, ultrasound urinalysis, fecal analysis and urinalysis, or an MRI of the lumbosacral spine.
3.
Let's pick anything with the buzzword in it, shall we? Brilliant. Okay, so blood work, we had a stress leukogram, mild regenerative anemia again, and a little bit of an increase in alk phos, nothing too interesting. Urinalysis, USG 1.040, some protein, some blood, and it was a mid-morning free catch sample. Okay, so the spleen and hepatobiliary systems were unremarkable. Gastrointestinal tract was within normal limits on examination. The kidneys had a slightly poor corticomedullary junction, and the adrenals were approximately 0.7 centimeters, measured at the caudal pole bilaterally, which could be considered a little bit big for a small Shih Tzu. But my concern in this patient was a stress hyperplasia, because they weren't massive. But the lower urogenital system, however, does anyone want to have a go at describing the image on the left here, which is our patient's prostate? On the right, you can see is an image of a normal prostate from another neutered male of a similar size and similar age.
It's grossly enlarged anyway.
Absolutely massive.
With a heterogeneous echogenicity.
Very good.
With what looks like some vacuolation maybe at the top of it.
Yeah, absolutely. Yeah, very heterogeneous. Totally agree. It's a very mixed echogenicity. Looks quite like a heterogeneous in echo texture as well, quite coarse. And like you said, it looks most vacuolated at the top part. Slightly irregular in shape maybe, but could just be the probe applying pressure. massive, okay, massive in size, 3 to 4 times the size it should be for a neutered male dog. That's good description. Well done. Okay, so we can tell this patient has prostatomegaly. So I'd like you to list 4 causes, if you can, guys, of prostatomegaly. There's, of course, diffuse and focal forms of prostatomegaly.
BPH.
BPH, number 1, top of our list. Second?
Prostatic neoplasia.
Yeah, prostatic neoplasia. Third? I always find all his medicine to be amazing, by the way. You've always got such great medicine knowledge. So what was the third
yeah, I can't ultrasound for hell, but I've got good
I'm sure you can. What was your third one, Orla? I think you can.
Prostatitis, but I don't know.
Prostatitis, fantastic. And 4?
Abscess?
Yep, abscess or cysts. So your focal lesions, abscesses or cysts. Fantastic. So you gave me 5 there, guys. Fantastic. Okay, so BPH occurs primarily, of course, well, in intact male dogs. So it doesn't really fit our guy. Prostatitis occurs far more commonly in intact male dogs. Cysts and abscesses, both of them, far more common in intact male dogs, which leaves one real differential here. And I'm going to leave you hanging for another slide or two. Okay. So would anyone have a go at answering these questions for us? Question number 1, what transducer has been employed and give a reason why? What type of probe is this?
A convex probe.
It's a microconvex probe. Fantastic. Why have I used a microconvex?
Because it's good at the Jesus.
Do you think I should have used a microconvex?
The frequency is high, so it gives good definition for superficial structures.
Fantastic. Yeah, I would say a microconvex probe is a mid-range frequency probe. So it's not super high. It does give reasonable penetration, reasonable image quality. Fantastic. Okay. Would anyone say I should have picked a different probe?
You could have used the linear.
Fantastic.
You could argue. Yeah.
Yes, we can argue, Jeff, that I should use a linear probe. It would, of course, provide superior image resolution. So a linear probe would have been fantastic. There's a specific reason I chose the microconvex probe in this patient, because I could have absolutely imaged this patient only with a linear probe, but I struggled to get into the pelvic cavity with the linear probe. Okay, so the linear probe is wonderful, but it struggles to sometimes peer around corners, peering into the pelvic cavity. And you'll see some linear images of this patient, and I can't see the whole prostate with it. I just couldn't. So I had to move to the microconvex probe to kind of push my way in a little bit past the bladder to image that prostate a bit clearer. Okay, so I know I always say use a linear probe in smaller patients, but sometimes the footprint can be cumbersome. Okay, what is the arrow highlighting in this image?
Calcification.
Very good, calcification. So this is mineralization of the prostate, and you can see that really nice distal acoustic shadow present there, and this is cast by that hyperechoic foci of mineralization. And mineralization is predictive of prostatic neoplasia in castrated male dogs, conferring a sensitivity of 84% and a specificity of 100% for prostatic carcinoma specifically. Okay, so I always check the prostate in a neutered male dog, always, and if I ever see signs of calcification, I'm concerned. Okay, very good. And what is the most likely differential diagnosis in this patient?
Neoplasia.
Yeah, prostatic neoplasia, prostatic carcinoma most specifically. So my concern for this patient initially was prostatic neoplasia due to the signalment, history, and ultrasonographic findings. It's not a common pathology, so you might see it, I think it's approximately 0.2 to 0.6 prevalence in the canine population. And of course, it's far more common in neutered males, with a breed predisposition and perhaps noted in Scottish Terriers and Shetland sheepdogs as well. So I've got another image here. This is the linear probe, and you can see here I couldn't see the entire prostate with the linear probe. I tried. And you can see the prostate and the neck of the urinary bladder here. So with this longitudinal plane, you can actually appreciate the invasion of the urethra by the prostatic mass here, encroaching towards the bladder lumen. A little factoid for you here. Transitional cell carcinomas arising from the prostatic portion of the urethra may occasionally invade the prostate, and prostatic carcinomas may conversely invade the urethra. So just be careful of that, okay? They can either urethral tumors can invade prostate or prostate can invade the urethra. So I continue to scan in this region and focus next on the medial iliac lymph nodes. So prostatic carcinomas have metastasized in what percentage of patients at the time of diagnosis, typically? Any idea?
40%?
Nope.
No.
Yeah.
Greater than 80.
Yeah, greater than 80. Isn't that terrible? Greater than 80% at the time of
80.
diagnosis. So the medial iliac lymph node you can see here in this image from our patient is hypoechoic, rounded, with increasing surrounding echogenicity. And these are some of the hallmark features of a lymph node that might guide our clinical judgment more towards a metastatic rather than a reactive node. So remember the medial iliac lymph nodes, they're located at the trifurcation of the aorta, where the aorta diverges away to form the left and right external iliac arteries. So ideally in a small breed dog, does anyone remember the size the medial iliac lymph node should measure in width? Anyone remember? Sound of silence. So it should measure less than 5 millimeters in a small breed dog, and I would want less than 7 millimeters in a bigger breed dog, but the cutoff is usually a centimeter. Okay, so the literature suggests that up to a centimeter can be normal, but we tend to like less than half a centimeter in small breed dogs. And you can see here this is grossly enlarged. So where do prostatic carcinomas most commonly spread to? Does anyone know? So they most commonly spread to the wings of the ilium and the base of the spine, okay, the ventral aspect of the lumbar spine, and the medial iliac lymph nodes, of course. They're the most common points of metastatic spread. So the medial iliac lymph nodes, base of the lumbar spine, and wings of the ilium. So metastatic lesions can be identified in the lungs as well, I think 44% of the time at diagnosis, and then the brain later in the course of disease too. So metastatic spread of the prostatic carcinoma to the ventral aspect of the lumbar vertebral bodies and the wings of the ilium is actually very common. And this is why the patients can often present lame, same with transition cell carcinomas. And our patient did have some mild intermittent hind limb lameness, according to the owners. So bony lesions typically appear as lytic, proliferative, or a mixture of both, which can be confusing. And you can appreciate that in the image at the bottom right here that I've stolen from this paper here. So how would this, in this image here, on the bottom right, compare to spondylosis? Any idea? Because I've seen these mistaken as spondylosis many times. And it's not. I was actually teaching this in a clinic about 2 years ago. And they said, oh, we had a case of a prostatic tumor where we had prostatic calcification. Oh, God, it could have been a prostatic tumor. And they said, oh, but the dog had spondylosis. And I said, let me see those rads. And it wasn't spondylosis. Once you know how to spot it, okay? So spondylosis is smooth new bone formation. And it typically comes at the edge, like from the end plates, okay? Whereas this is poorly defined new bone formation, kind of lytic, kind of proliferative, very variable, kind of moth-eaten sometimes, and tends to arise from the midline of the, from the middle portion of the vertebral bodies, not the end plate. And that's a defining feature. Again, you can see it quite clearly here with the black arrows where it's arising from, which is a bit different than spondylosis. Of course, when you've got severe spondylosis or DISH, that diffuse idiopathic spondylosis, or what is it, the DISH one, skeletal hyperostosis syndrome, that's it. That can kind of really throw you too, but it looks slightly different than this. Okay, so how might a definitive diagnosis of the prostatic pathology be obtained in this patient?
Could you do a traumatic wash?
Yeah, you could do traumatic catheterization. Oh, not traumatic, prostatic wash. Yeah, I find prostatic washes to be variable. I think this patient was quite painful as well, so I don't know how well he would have tolerated that under sedation. Okay, but he had hematuria too, so I would have gone for FNA of this. I would agree with Laura there. I would have gone for FNA. So FNA of the prostate and possibly the lymph nodes would be a good next step, in my opinion, as a diagnosis does require cytology or histopath. There is a minor risk of seeding carcinomas to the abdominal cavity, but this is negligible, obviously, in this case, as by this stage, metastasis has really already occurred in greater than 80% of cases. It's also important to note that secondary infection is not uncommon. that and inflammation, and they can commonly interfere with the interpretation of the cytology. And in Scooby's case, the owners declined further investigations at this point. So, of course, prostatic carcinoma, it was our most likely differential diagnosis for Scooby. FNA or FNB was declined. So there's a very, very poor prognosis once diagnosed. There's no effective curative treatment for prostatic carcinoma in dogs that I'm aware of. Correct me if I'm wrong there. Prostatectomy is not recommended due to the high incidence of urinary incontinence. Radiation therapy causes incontinence due to radiation-induced fibrosis of the urinary bladder, so that's not recommended. And the mean survival time is about 6 months. That's with treatment. So palliative treatment options include NSAID therapy, plus minus antibiotics. So secondary infection, as I mentioned, is common, affecting around 36% of dogs, often manifesting with those lower urinary tract signs as well. So there was a 2004 study that indicated an NSAID treatment delivered an increased mean survival time of 6.9 months compared to 1 month when the patient was left untreated. So Scooby was prescribed piroxicam, but was unfortunately euthanized, I don't think even a couple of months later after the scan due to a worsening clinical condition. Poor Scooby. Okay, case number 3. Short case here for us now. I'm going to meet Victor. He's an 11-year-old male neutered terrier cross. He has a history of cervical disc compression, fixed surgically 12 months previously with hemilaminectomy. Recent history of hyporexia and occasional vomiting. Owner reports as a bloated abdominal appearance. His neurological examination, I was his GP vet at the time, his neurological examination was within normal limits when he came into me. My most notable abnormal finding was cranial abdomen. Cranial abdomen was tender on palpation. So full bloods, urinalysis, biochemistry were performed and entirely unremarkable in this patient. So we did an ultrasound. That was the next step, shock horror. Moving on. So before we continue with this particular case, I just want to ask you, can someone describe these splenic lesions using the Röntgen signs I've given you here and possibly give me a diagnosis? The most likely diagnosis?
Approximately 1 centimeter diameter multifocal lesions within the parenchyma of the spleen. Hyperechoic.
Yep.
And
slightly heterogeneous.
Yeah. Well demarcated.
Pretty well demarcated, yeah.
And potentially a little bit more echo texture is probably the same as the parenchyma.
Yeah. So, I mean, I don't always jump. The echo texture, I'd say, sometimes you talk about echo texture, sometimes you don't need to, that kind of thing. I'd say they're slightly heterogeneous in echogenicity. The hyperechoic, mildly heterogeneous. They're reasonably well demarcated. They're not perfectly well demarcated. I can see the edges, but they're not crisp edges. They are on the mesenteric and antimesenteric surface of the splenic parenchyma, to be more specific. Okay, and I think you've done a beautiful job there of describing those. And what are they? Any idea? What would you say they're most likely going to be?
Nodules.
Nodules. I would call those a nodule indeed. Any idea of a more definitive diagnosis there for us?
Splenic nodules.
Splenic nodules is correct. Well done. Anyone see these before?
I can't remember the name of them. They're benign anyway, aren't they?
So this is a very, very common appearance for splenic myelolipomas. Okay, very, very common. I can't definitively say that they're not something else. I could stick needles in a sample, but these are super common finding in our older patients. You can monitor them if you want, stick needles in if you want, but very commonly myelolipomas look like this. So like little clouds inside the spleen, typically less than 1 centimeter. Okay, so now we can describe what we're seeing. What could a focal lesion represent in any organ? We've got this Chang acronym. Do you remember this? So C, can you remember what does C stand for?
Cyst.
Cyst for focal lesions. H?
Hematoma.
Yep. And?
Hemangioma?
Hemangioma is a type of neoplasia. So no. Hematoma, hyperplasia, and?
Hyperplasia and
hematopoiesis. Spleen. Sorry, I have to keep things moving, lads. What about A? Thank you for answering those. Abscess. Very good. N?
Neoplasia.
Very good. And G?
Granuloma.
And the all-elusive granuloma, fantastic. So you know your focal lesions on ultrasound. Well done, okay? And we've already said this is probably a myelolipoma, which would be a benign form of neoplasia, right? Okay, so these are our potential candidates for splenic nodules in the dog or cat. As we've discussed in the lecture, differentiating between these can sometimes be challenging when utilizing ultrasound alone, and FNA may often be necessary. So here are two ultrasonographic images obtained from our patient, now from the tail of Victor's spleen. So you can see there was a large 6 by nearly 8.5 centimeter round, capsular deforming, markedly hyperechoic, reasonably homogeneous lesion that had pretty good demarcation from the normal splenic parenchyma as well. And this mass was not cavitated, nor was there any subcapsular hemorrhage or evidence of abdominal effusion. So very strange presentation for a splenic mass. Would you guys agree?
Yeah.
It doesn't look like your usual cavitated splenic mass. It's a big mass, very hyperechoic, looks like a fluffy cloud. Now we've known about myelolipomas. So let's have a little look at our differentials for splenic lesions and see what might fit. So cyst, do you think a cyst is likely?
No.
So it's not anechoic, it's not round, encapsulated structure with distal acoustic enhancement. It's none of those. Okay, abscess?
No.
I don't think so. You can't see a nice thick wall or overt encapsulated structure. Can't rule it out, okay? But I don't think it's likely. There's no distal acoustic enhancement artifact present either. Hematoma?
No.
Highly unlikely, okay? Unless there's a big clot in there, but highly unlikely because typically they're cavitated lesions, which cannot easily be differentiated, of course, from your hemangiomas, from the malignant hemangiosarcomas. Again, no distal acoustic enhancement artifact, not cavitated. What about hyperplasia or extramedullary hematopoiesis?
No.
Why not? What's your reason? Because I have a reason for them not likely being that.
It's very focal for hyperplasia.
Okay. You can have single nodules that are hyperplasia, okay? Single nodules of extramedullary hematopoiesis, but they're typically lesions that are less than 3 centimeters. Typically, that is. So usually they're small, less than 3 centimeters. This thing's massive. What about granuloma? Is that a possibility?
Yeah.
Yeah, sure. Granuloma can be anything. Neoplasia?
Yeah.
Yeah.
Yeah, it has to be on our radar here, as the others are all rather unlikely. So for me, this lesion just looked like a giant myelolipoma. Do you guys agree? It looked like a bigger version of those little clouds we saw.
Yeah.
Hyperechoic, rather homogeneous, reasonable demarcation. I had just never seen, at this point in time, I'd never seen one this big before. It's super rare, but it can occur. So I put my money on it being a big myelolipoma. So given the remainder of the abdominal ultrasonographic examination was unremarkable and chest radiographs were clear, the owner declined FNB or FNA and elected to perform a splenectomy. And they sent the spleen for histopath, and it was a splenic myelolipoma, just a really big one. The histopath people were fairly happy with that as well. So it was a very fun case, great result for the patient. And since this case, I've seen 2 more of these giant myelolipomas that have been confirmed with histopath. Rare presentation, but it does occur. On to case number 4, our penultimate case. This is my favorite cat. This is Puddy, quite literally my favorite patient. 14-year-old domestic short hair, female neuter domestic short hair, persistent history of mild diarrhea and intermittent vomiting. You can tell I like GIT cases. Eats food from numerous households, multiple visits to a variety of veterinary clinics. Okay, so she's had so many partial workups, and I love her owners, but they are clinic hoppers. I was the 16th vet they had visited. 16th time it came. Okay, so I felt the pressure. Luckily, I could scan, but 16th clinic that they had visited, 16th vet they'd visited. And the owners had never given the vets chance to do a proper workup. I think that's what kept happening here, okay? They kept moving before anything was sort of done, okay? So unfortunately, this is on the owners, okay? So abnormal clinical findings, moderately pale mucosa, mildly distended abdomen, but super poor body condition score, 1.5-ish out of 5, I would have said. She was pretty skinny. So what transducer has been employed for this ultrasonographic study and why?
A linear probe.
Good. Why have I put the linear probe on this patient?
Good for
Better
small.
for superficial.
Yeah. And I actually was talking to someone recently and they were saying, oh, you know, we never use a linear probe. Why would you pick a linear probe when you've got the microconvex? Barely would ever pick up the linear probe. Do you remember I was telling you guys about the consensus statement that was released in 2022 about how to perform an abdo scan? They're now suggesting that every clinic should have a linear probe. It's what they're actually recommending as gold standard, and that all small patients should be scanned with a linear probe. They reckon that 80% of small animal patients should be scanned with a linear probe, not a microconvex anymore. So they've really stated that in the paper. Okay, so a linear probe has been used. Why have I used a linear probe, guys?
It's good for superficial.
Yeah, for superficial
It's a
structures.
small cut.
Yeah, high frequency, good for superficial image resolution, and it's a small patient. Fantastic. Okay, so with sonography, there was concern for the gastrointestinal tract pathology. So what do the numbers in this image represent, anatomically speaking, or within the abdomen? Number one? Well, one is bowel loop. Would you say? I can't tell you if it's the duodenum here, I actually can't, but bowel loop, would you agree?
Yep.
Yeah.
Yeah. Two?
Bella?
Sorry?
No, never mind.
No, you might be correct. I can't hear you.
It's
Sorry.
duodenal papilla or something like that. No.
Oh, sorry. Yeah, it could be actually the duodenum with the duodenal papilla. I don't think it is. I'm actually pointing to the black stuff with that number
sorry.
2.
Okay.
Sorry.
Effusion.
Effusion, very good. That's my bad there, Ola. Sorry. Number 3.
Is that the pancreas?
Mesenteries. It could be pancreas. I can't tell you properly in this, but yeah, I'd say just hyperechoic mesenteries there. Very good. Okay, so another interesting abdominal ultrasound. So a little reminder here about a little reminder slide about diffuse changes in wall layering, and that typically diffuse changes affect the muscularis and submucosa most commonly when it comes to changes in thickness. Okay, so you've got diffuse changes affect the muscularis and submucosa most commonly. So we know that with the muscularis, when it becomes thickened, we can think about inflammatory bowel disease. We can think about tumoral infiltration or distal obstruction. So if you have a focal mass or a foreign body or an intussusception, something that stops the aboral passage of food, we can end up with a thickening of the muscularis layer of the intestines proximal to this obstruction due to work hypertrophy. Okay? When the submucosa is increased in thickness, you can think about parasitic disease. As I mentioned, there was one book that really focused on this food responsive enteropathy rather than a steroid responsive enteropathy when the submucosa was thickened. Slightly tenuous, but I have absolutely used that book and used this particular thing this book was talking about a couple of times as well. When it comes to IBD, we have our lymphoplasmacytic enteritis, and in cats, more specifically, eosinophilic enteritis. Okay. So which layer of the jejunum do you think here is thickened? Quite hard to tell. Sorry? Muscularis, very good. So it's sometimes really hard to note which layer is which. So I always try and find the middle there, and I know that that's the lumen. So that hyperechoic part in the very middle is the lumen. Then you've got the muscularis on the outside, okay? Well, mucosa on the outside of the lumen, submucosa, muscularis, and the serosa on the very outside. It is quite hard to see here, but the muscularis is absolutely thickened. So these diffuse changes affecting the muscularis layer have caused the muscularis layer to equal the mucosal layer in thickness. It's pretty thick, and this can be termed that 50-50 mucosa muscularis ratio. Alternatively, an increased thickness of the muscularis layer may be determined by comparing it to the submucosal layer, as they should be of roughly equal thickness. A muscularis layer that is over 1 or 1.5 times thicker than the submucosa is concerning for infiltrative disease. Okay, so now this section can be this 50-50 mucosa muscularis ratio, can be a normal anatomical appearance in a particular portion of the small bowel, that's the ileum, okay? However, if this short section of bowel has been tracked one direction and then the other direction a short distance and does not reach a cecum on either side, well, then it probably is an altered jejunal loop. And then the considerations for differential diagnoses in this particular case are going to be lymphoma and IBD. So you can see here the blue arrow points to the mucosa and the pink arrow points to the muscularis. Do you guys see that, yeah?
Yeah.
Good. Okay. So diffuse intestinal changes in cats are more commonly associated with lymphoma than IBD, but IBD presentations like this are common. Okay, that's what this study here reports, and I absolutely agree. I see a lot of IBD cases like this. So a brilliant paper by Danielle et al. In 2014 assessed ultrasonographic thickening of the muscularis layer in feline IBD and lymphoma cases. It's a great paper. And they determined that with both diseases, the muscularis layer was really the only layer affected by an increase in thickness, and then it may be up to 2 times thicker than in healthy felines, which is mad. In both healthy and disease patients, the other bowel layers remain unchanged. So that's very important there. It is the muscularis layer that gets affected. They reported that both diseases can occur simultaneously, and that's not uncommon. And it's been hypothesized that chronic inflammation is actually the inciting event to lymphoma in some cases. Another study showed that 60% of cats with lymphoma of the gastrointestinal tract had a previous history of clinical signs that could be attributable to IBD, so kind of chronicity. So perhaps there is a continuum of disease from inflammation towards neoplasia, and that's why they appear so similarly ultrasonographically. And additionally, cats with lymphoma are typically older than those with inflammatory disease as well. Interestingly, they reported that IBD is more prevalent in the duodenum and lymphoma in the distal jejunum. However, full thickness biopsies are going to be required for a definitive diagnosis. So, diagnosis, IBD versus diffuse intestinal lymphoma for Puddy. I think that's our differentials here. And I was considering IBD to be more likely given the chronicity of this case, but I informed the owner that, of course, with a chronic IBD, it could lead with this continuum to lymphoma. So I wasn't 100% certain. So I recommended full thickness biopsies and lymph node aspirates. Both were declined. Okay. So treatment plan for this patient was fastidious dietary control, less important in cats than dogs, but I still wanted to get her on a ZD diet. Steroids, I recommended fecal analysis as well, because she'd had problems for so long, and a repeat ultrasound in 12 weeks. Now, fastidious dietary control in this particular patient was going to be rather challenging, because she was a roving cat, okay? She used to go and visit every other house in the neighborhood, far and wide for extra meals, so it was going to be quite hard in this particular case. Anyway, 3 months later, the owner reported that Puddy was doing really rather well again. She had no diarrhea, she was gaining a little bit of weight, and she was up for cuddles again, which was great. And look at the jejunum now on the repeat ultrasound. Totally normal. Okay, that was within 3 months. So routine checkups were set up with monitoring of the body weight every 6 to 12 months, and we started to taper the steroids as well. So adherence to a specific diet would have been mighty, but even following canvassing the neighborhood, she actually got a collar and a tabard for the cat, for Puddy, that indicated that her cat should never be fed by anyone else. She was still getting food elsewhere though. So coming off the steroids was not actually an option for Puddy. Coming off the steroids led to a deterioration clinically. So now the patient was doing very well, actually had a good diet at home and a low every other day dosing of Pred. Now, this cat's still going strong. It's 3 years on. She's now 18 years old. Puddy is doing great still. Occasional flare-ups, but primarily healthy. And here are the images from her 5th abdominal ultrasound. This was the last scan that I have done for her a few weeks ago. And the last scan before this was over a year ago. And the bowel loops were perfect, absolutely normal. Okay. So I think IBD was our most likely diagnosis there. But what have we got going on here? We've actually seen this image already today. Do you remember what this was?
Mineralization in the
intrahepatic mineralization of the biliary tree, absolutely. So copious biliary tree calcification in cats is really rather undocumented. So when I came across this, I found this very odd. I actually did an x-ray to confirm how vast this calcification was. The x-ray is beautiful. I don't know why I didn't put it in here for you. It's quite cool. But it really is not very common to see in cats. So I started looking it up because, of course, biliary tract carcinomas were on my differential list. But I mean, the literature is sparse about this. There was 2 papers with 8 cats or something like this in total. So it's an interesting finding, poorly documented in cats. So the options for this particular finding include an incidental age-related finding. Was the possibility because Puddy was quite old. Dystrophic mineralization due to steroid administrations, that's possible in this patient. Secondary to cholangitis, but there had been no evidence of this in this particular patient ever. Biliary tract carcinoma, but again, I didn't see any evidence of this, and it is considered rare in cats. So chatting to this patient's primary care practitioner, so I'm now not this cat's primary care practitioner because I stopped being a GP vet. But it turns out that Putty is now continued on the every other day dosing of steroids with occasional increases in the dose when the clinical signs flared up. Other immunomodulatory drugs were not considered effective in her case. She wasn't home enough to make sure that she got them. She kind of came home every second day, so that kind of worked with the steroids. Overall, I personally felt that the dystrophic mineralization of the biliary tree was either due to an age-related change, but also more likely due to the exogenous steroid administration. So Putty continues to be monitored and is my favorite feline patient. So a cool case for you. And the final case of this evening, we're running a little over time, but we started a little bit later, so I think that's okay. So it's not a very long case. We'll look at Crumpet. So Crumpet is another 12-year-old, sorry, they're all 12-year-old female neutered Dachshund cross that I saw very recently, a few weeks ago. She presented with lethargy, a recent history of inappetence, whining at home, and concern for some abdominal discomfort. And she presented 3 times recently in recent history to the primary care practice, I think within the last 6 months, with suspected pancreatitis, and was treated empirically for that and did well after every episode. Abnormal clinical findings on the day she presented to me: pale mucosa and tender on abdominal palpation. She was actually in hospital, sorry, at the time that I saw her. She'd been hospitalized for the 3rd time there for suspect pancreatitis. So blood works were done first. ALT up a little bit. Of course, upper range is 125. Amylase, lipase were very elevated, as you can see here. And the patient was treated empirically for a pancreatitis in hospital. And they recommended some imaging. We've got an older patient here who's had repeated episodes of cranial abdominal pain. And concern for pancreatitis. So we did indeed do a little abdominal ultrasound. So the abdominal ultrasonographic examination was actually remarkably unremarkable, apart from this particular image here. We have an impressively large and invasive right adrenal mass lesion. So studies indicate that between 20 to 48% of adrenal neoplasms invade the caudal vena cava in dogs. So we're going to watch this clip through a couple of times. You can see here now the caudal pole of the right adrenal gland, the cranial pole of the right adrenal gland that's invading the caudal vena cava, and the left adrenal gland over there as well. Do you agree it's a beautiful video? I think I've watched it about 1 million times, I would say, through at this point. I think it's absolutely stunning. Poor dog. Okay. So before we go any further, I want to ask you, how successful is your adrenal gland hunting going? I'm actually desperate to find out. How are you finding the hunt for the left and for the right adrenal glands?
Mine's very hit and miss.
Hit and miss for both, or just left, or just right?
The right one I find hard to find.
It is hard. Yeah, it took me about 2 years to be able to find the right one consistently. Left one going okay for you?
Yeah, when I turn the patient around. That's helped out.
That's helped, doesn't it? For the right one anyway. Anyone else? Would you say you guys are finding it more than 50% of the time?
Finding the left
Not the right one,
most of the time.
Left
The
most of
right.
the time. Well done, Jeff. Well done. Right?
And then the right is like, could be anywhere from 20% up to, yeah, maybe between 20 and 40, maybe. Something like
Very
that.
good. That's fantastic. That's amazing. And she said you're not scanning all the time at the moment, but the more you scan, again,
The more, well, because I can't stop, I think they just don't want me to keep scanning adrenals. They're like, would you ever leave us alone?
Definitely. You're like, I'm proud of this adrenal hunting. It's great. But you can see that, I've made significant diagnoses just based on being able to find the adrenal glands and confidently say that I can find them. So when I can't, I know there's an issue, So we can't find organs routinely. And, if you can find an image in an adrenal gland, your anatomy is okay. And that you're able to find the smaller structures. So your hand movements are getting good. So that then imaging a kidney is going to be a piece of cake, okay, compared to finding an adrenal gland. So that's why I think it was quite fun to be imaging the adrenal glands. Anyone else? How's the left adrenal hunting going? Kira? Is Kira still there?
Yeah.
Hi, Kira.
I feel like find the left probably most of the time, or I'd be okay find the left, the right. I found it in a cushion-eyed patient recently, which is nice. Then it came back positive actually came back negative on the ACTH stim and positive on the low-dose DEX.
Yeah, fantastic. Well done.
That was nice, but then very, very hit and miss if they're like normal, I think, for the right. Yeah.
The right is very hard to find, guys. It really is. When we meet in June, let's go over the adrenal glands again. Okay. And anything else, obviously, gather together anything you want to go over. We will do echo, but we can take our time going over the other parts as well. Okay, so we're going to look at the left adrenal gland very quickly again for your hunting, just to increase your numbers again here. So this is the left adrenal gland. I have no arrows, unfortunately, popping in to point to anatomy. So I don't know if anyone wanted to narrate this video for me, mentioning the anatomical landmarks as they go. Anyone want to give it a go, or do you want me to do it first and then someone try afterwards?
A good idea.
I'll go first, right. That's the left kidney. We can see the left renal artery hooking onto the aorta underneath there. Got lovely peanut left adrenal gland coming in there. I'm going to watch it again. I'm going to show you guys those two anechoic dots that are the celiac and cranial mesenteric arteries. Do you see them there at the bottom? And every now and again, they're not very well demonstrated there. But we see our beautiful peanut. You can see a bit of the peanut first, like that, and then as I rotate my probe clockwise, you can see my full peanut comes in. So that's a slight rotation of my probe clockwise, about 15-20 degrees, makes the full peanut appear a lot of the time for us. Otherwise, we see sort of one pole and then the other pole. You see that? And in this particular patient, we can see the cortex and the medulla quite nicely. Remember, you don't always see the cortex and medulla. Sometimes you do, sometimes you don't. And sometimes the cortex is brighter, sometimes the medulla is brighter, and it doesn't mean anything, okay? So that's one to mention there for you. So left adrenal gland, there's several ways to find it. Remember, the adrenal gland is going to be situated just medially to the left kidney. So if you're imaging the left kidney, you can fan medially towards the base of the spine to be able to image those great vessels. And it's going to be next to the aorta, next to the left renal artery. Okay, I'll move on just for time. Okay. Right adrenal gland, so we're imaging the patient on the right-hand side. They're lying on their left. It's a very pretty image here. This is a normal right adrenal gland. The vessel that's closest to me that's big there is the caudal vena cava. The vessel that's furthest away from me underneath is the aorta. You can see that lovely right renal artery hooking off the aorta there that we had. Wait for the nice big right renal artery again. Do you see it there? Lovely. And you see there's two dots, there's two anechoic dots in the middle of the image. That's the celiac and cranial mesenteric arteries. And we know just behind that in our image, so just proximal to that, is going to be our right adrenal gland, which we can see the beautiful arrowhead shape of that right adrenal gland, which is attached there to the caudal vena cava. Can you all see the right adrenal gland?
Yeah.
Beautiful, lovely arrowhead right adrenal gland there. Fantastic. Okay. So we're going to watch the right adrenal hunt in slow motion now for another patient. I've really slowed it down. You can see the right adrenal gland popping into view there, adjacent to that caudal vena cava. Okay, so what vessel is this? It's the caudal vena cava. How could I confirm that the thing that I'm pointing to is indeed the right adrenal gland? What might I be able to do to confirm it's the right adrenal gland if I was in any doubt?
Color Doppler.
Color Doppler.
Yeah. Very good. I could pop color Doppler onto it. And that I've done in this next video here, next image here. Sometimes as well, it's easier to identify the right adrenal gland in a transverse plane, observing it lying adjacent to the caudal vena cava. So I know a lot of specialists like to image the right adrenal gland like this in a transverse plane. I've had less luck with this, but when you do pop color Doppler on like this, it is very easy to spot the difference between the two. And I've got a beautiful little question mark highlighting a gorgeous artifact here for us. What is the artifact called?
Edge shadowing.
Not actually. There is actually a slight edge shadowing. You're dead right. There is an edge shadowing there, but it's actually in the middle of the artifact, which is the distal acoustic enhancement artifact or string transmission due to the vessel. Well done. Okay, so back to crumpets specifically. We had left and right adrenal glands were asymmetrical. The left adrenal gland was a little bit bigger than it should have been, so definitely enlarged. And the right adrenal gland was massive. Okay, not as big as I have seen them be, but she was not a very big dog. She's a little dachshund cross. So 1.6 centimeters was the biggest measurement I got of the caudal pole or cranial pole of this particular gland. So you can see both glands are big, but the right is particularly big. And as we can see here, invading the caudal vena cava. Okay, so the caudal vena cava was notably enlarged and actually about 2 to 3 times wider than the portion of the caudal vena cava that was cranial to the tumoral invasion. So this was actually the first abnormality I noticed in this patient, was I was scanning the vessels caudally, looking at the medial iliac lymph nodes, working my way up the abdomen, and I noticed the caudal vena cava was far too big. And it was far too big because we had this massive obstructive lesion. You can even see the flow of blood there within it. Massive obstructive lesion at the level of this mass. So application of color Doppler was pretty. You can clearly see the direction of flow around the neoplastic invasion. So what color variance map have I used here? If I've got blue away and red towards?
Bark.
Yeah,
Bart.
the Bart
Oh,
map.
yeah.
Fantastic. Most people do use the Bart map, but some people don't. So just be aware that the blue away, red towards only works if you are using the Bart map. Very nice. And you can see in clip form here, we've got some turbulent flow. Probably the gain's a little bit too high here. Patient was panting a little bit, but you can see that that is almost totally occluded the caudal vena cava. You see the caudal vena cava stretching to get round it. There was almost no region of the caudal vena cava as I was fanning through that I could see clear blood flow. Okay, so really, really challenging for this poor blood to get back to the heart in this patient. So with regards to adrenal masses, they can be benign, malignant, endocrinologically active, or endocrinologically inactive. So helpfully, there are a couple of ultrasonographic findings that might be indicative of malignancy. And these are, for example, a localized or generalized loss of normal shape. Often they're more than 4 centimeters in size in any dimension. Often they're heterogeneous. There can be calcification in 30 to 50% of cases. They can have an irregular capsular margin, and they can invade the surrounding structures. So adenocarcinomas far more commonly exhibit mineralization than pheochromocytomas, which only demonstrate mineralization about 10% of the time. Okay, so remember, calcification as well of the adrenal glands in cats is very normal. We regularly see calcification in the adrenal glands of cats, but in dogs it is linked to adenocarcinomas particularly. Pheochromocytomas, on the other hand, they invade the caudal vena cava at a reported rate of roughly 30 to 80%, although most studies do agree that there is a greater than 50% risk of CVC invasion with a pheochromocytoma. So adenocarcinomas more likely have calcification, and pheochromocytomas more likely invade the surrounding structures. So regarding the invasion of surrounding structures, surrounding tissues and structures, is this feature of malignant adrenal neoplasms, which can actually make it particularly difficult to discern whether there is a mass originating from the adrenal gland itself or coming from the hepatic parenchyma or the kidney, which is just obliterating our visualization of the normal right adrenal gland in that vicinity. So sometimes it can be really hard to say that this lesion is indeed an adrenal gland mass. So these are your last few questions of the evening, and then we'll stop. So how would you expect the adrenal glands to appear ultrasonographically in the following clinical situations? Increased, decreased, or equivocal in size? Okay, so if you had pituitary dependent Cushing's, what size would the left adrenal gland be?
Increased.
Increased. Right adrenal gland?
Increased.
Increased.
Okay, Addison's disease, left?
Decreased.
Decreased. Right?
Decreased.
Decreased.
Yeah, and with Addison's, they can possibly not even be seen at all. So for Addison's disease, they're typically less than 30 millimeters, less than 0.3 centimeters. Okay, 30 millimeters. Systemic stress, for stress hyperplasia.
Increased.
Increased.
Yeah, they can be normal or a bit increased. Absolutely. What if you have if you have an endocrinologically active left adrenal mass?
Left increased.
Increased.
Normal.
The right is smaller.
Right is smaller. Yeah, atrophy as a result. Okay. What about a non-endocrinologically active right adrenal mass?
Right increased.
Increased and left normal.
Yeah, normal or unchanged, exactly, and the right increase. Very good, guys. Fantastic. So you understand how to use ultrasound then to help maybe limit your diagnosis list. Fantastic. So what is the most likely diagnosis then for crumpet? We have a right adrenal mass lesion that's mildly heterogeneous. It is invading the caudal vena cava, and there is no evidence of mineralization. What is my most likely diagnosis?
Three.
Yeah, pheochromocytoma. Absolutely the most likely here, for sure. Very good. Okay, so what steps are going to be most diagnostically rewarding? The owners will consider all options at this point. Do you think they should go for chest radiographs, ACTH stim test, and blood pressure? Should they go for plasma norepinephrine test, contrast-enhanced CT of the chest and abdomen, and blood pressure? MRI of the adrenal lesion or tissue core biopsy of the adrenal lesion?
2.
Sorry?
2.
2. I would absolutely go for 2 as well. Fantastic. Why would you not go for 4?
Because you're in the caudal vena cava.
Yeah, good luck.
Good luck. Good luck. So it's in the caudal vena cava, absolutely. Even FNAing these lesions, if you are suspicious of a pheo, can lead to a massive hypertensive crisis and the patient will die. So just don't FNA adrenal lesions unless you really have to. MRI of the adrenal gland, absolutely kind of a no-go in dogs, really. They move too much, even with sedation and anesthesia. Chest radiograph's not very helpful for us here. So the plasma norepinephrine test, brilliant. Okay, it's highly sensitive and specific biomarker for diagnosing canine pheochromocytoma. Contrast-enhanced CT of the chest and abdomen will allow us to assess for metastatic lesions and surgical planning, and a blood pressure, of course, if we're considering how the patient's doing clinically, but also whether it's a pheo or not, because very often they're hypertensive. Though I've had a couple that have been hypotensive actually as well. Okay, so why would CT be beneficial in this patient? So a CT scan can gather large volumes of data very quickly, imaging both the abdomen and thorax with several image series in a few minutes. So not only does the three-dimensional nature of CT with the multiplanar reconstructions and volume rendering allow us to better assess the lesion prior to surgical resection, it can also help us to identify metastatic lesions far earlier and with more certainty than the X-ray. Okay, so contrast-enhanced CT scans going to demonstrate various contrast enhancement patterns as well of lesions that may be more particular to a specific pathology as well, and might help guide you further, whether it's, say you think it's a neoplasm, it might help you say, well, it's this particular type of neoplasm due to the contrast enhancement patterns. So we have here a contrast-enhanced axial soft tissue reconstruction that depicts a large, irregular, heterogeneous right adrenal mass adjacent to the caudal vena cava and right kidney. This is a different patient, not our crumpet here. So CT is beneficial in this particular situation as the right adrenal gland shares that adventitia, as we've mentioned, with the caudal vena cava. It's very close to the right kidney, which is cuddled up to the caudate process of the caudate hepatic lobe as well. And this all happens in a very small anatomical space, very often underneath the ribs. So therefore, these particular neoplasms can be challenging to confidently discern and delineate with ultrasound alone. And they really do lend themselves to diagnosis by CT far more readily. I've had 3 right adrenal neoplasms in the space of the last 2 weeks. And I would say crumpets was the easiest to confirm. So I recommended, I felt in this particular case, it was more likely pheo, and I've recommended plasma norepinephrine and CT and blood pressure. My other 2, I think, are more likely adenocarcinomas, and I've recommended CT. But 3 in 2 weeks is pretty impressive. So regarding crumpet, the owners are currently deciding which route they wish to go down, and she's booked for a blood pressure check this Wednesday. So that finishes up our case studies. I want to ask, does anyone have any questions about our cases tonight? Have you found the case studies helpful?
Yes.
Yeah.
Great.
Into clinical perspective on it, is it?
Yeah, I must recheck my cat tomorrow.
Oh yeah, I have to reply to your message about the cat. I'll reply to your message. Sorry, Laura, I was in my bubble all
you're
day.
fine. Yeah, I don't. I'll use a linear probe for the intestinal or for her whole abdominal scan.
It will make a difference for sure.
Yeah, he definitely has like hyperglycemia as well, which I'm like, I don't know if it's as well.
Is it a weird DKA? Is it really weird DKA?
Yeah, I don't know, like it's so strange, and every time we take a blood sample it's something different, like, so I'm like, I don't know.
I looked at the bloods, it was bizarre to me. I don't see such extreme changes with GI tract, and the GI tract didn't even look that bad, I'll be honest with you. It wasn't horrific.
Yeah, I don't know, it's just I don't know, it was strange. Now I'm gonna have a go again. I might do a little bit it was very sore today, so I might give him a little bit of sedation. Just
feel free to video call tomorrow if you want me to have a little look with you while you're scanning.
Great.
Don't hesitate, guys, ever. If anyone needs to do that, don't ever hesitate. Just send me a message and just call. If I don't answer, it's not because I'm ignoring you. It's because I'm with a toddler or currently scanning. So just call again. Okay. Any other questions, guys?
No, I think
no. So just very briefly here, if everyone doesn't mind, maybe some of you have done it already. I posted up on Instagram. I'm doing a survey of ultrasound in general practice. Takes about 3 minutes for you to do. If you could forward it on to all your ultrasound friends or vet friends, just vets in general, would be amazing. Only for vets, not for nurses. Just 3 minutes looking at how ultrasound is used in general practice. And it's just helping me to further refine my teaching because I'm finding that actually some very interesting results are coming out of this actually so far. I'd like to get 250 answers. So if you could forward it on to your friends, I'd be so appreciative.
that'd be grand.
And do it yourselves.